Thank you, Mike. Thanks everyone for having me on. It's really great to be here this evening. This is not something I do very often. It's not something I do professionally. I'm not a professional speaker or lecturer. I'm a clinician, just like many of you. I also see some familiar faces and friends on the webinar tonight. So hello everyone, good to see you. And it's awesome to get to spend a few minutes with you. This is not about me at all, but I wanted to, I feel like in the lectures I've attended, it's important to see that, the person lecturing is a real person with a real family and a real life outside of dentistry. So I just wanted to throw a picture up real quick. This is my family. My wife Heather here in the back, and we have four children, 15, 12, 10, and 8. Our youngest two, they're about the same size, so they look like twins, but they're really a couple of years apart. Um, I I have this page up. I titled it Fast Facts or Facts About Me. And a wise man told me to throw in a few facts so people kind of remember who you are when you meet them in the future and things that you did. So I'm going to give you an explanation on these three photos that I have here so you can maybe connect and relate a little bit to me a little bit better. So the first photo in the upper left, this was taken when we were living in Detroit, Michigan, 5 or 6 years ago. And so this was just at the kids' playground around the corner from our home. And the fact from this one, or the interesting thing, is that we have four kids, and they were born in four different states. So I mentioned their ages. They're all about a couple of years apart. And so when I think back on raising kids and having children and having four kids in four different states in such a short amount of time, it's just wild and crazy. So maybe some of you are from some of the same areas. So Carson was born in Las Vegas, Nevada. Mia was born in American Fork, Utah. Ruby was born in Payson, Arizona. And Luke was born in Ellensburg, Washington. And then our puppy up there was born in Michigan. So he had to stay on the Michigan state. The bottom left photo, this is a picture from graduation from dental school. So an interesting thing about me is that English is my first language. I started learning Spanish when I was 19 years old and moved to Santiago, Chile. And I did dental school at the University of Puerto Rico. So although English was my first language, I learned dentistry first in Spanish. And then it was kind of Spanglish, but a lot of the words, once I got back over to the mainland US, I had to kind of ask, I'm trying to think of an example. Like, for example, the dental papilla, I wasn't quite sure how to pronounce it because in Spanish we called it papilla. So there were a lot of things that I had to learn and pronounce a little bit unusually for a native English speaker. And then on the right side, this is just kind of a snapshot that one of my assistants took of me working recently. And I am right-handed in most things. I do almost everything right-handed, but there are a few important things and one major thing that I do left-handed. So I write with my left hand, and I eat with my left hand, and I do dentistry left-handed, which if we've got 50 or 60 of you on the call right now, so any of you that are left-handed dentists, there's a struggle. In a world where operatories are set up backwards, it's hard to be a left-handed dentist. All right, we'll get on to more important things. It was early this year in 2023, in February, I got a couple of just kind of texts out of the blue from BJ, who you saw on the call earlier. And he's a gentleman that I knew from when I was a resident at the University of Detroit Mercy. And he texted me and he said that he was with Avalon Biomed, who I was familiar with the company because of the Neo Putty, but I didn't know a whole lot about the company other than it was a company that produced some bioceramic type materials. And so he said he had some exciting products, including files that he wanted me to try that he thought that I would really love. And I knew BJ was from Illinois, and so he wanted to make a trip to Wichita to show me the files. I said, no, I'm good. I've been using the same files and the same sealer for 5 years. I've done thousands upon thousands of cases. I'm just going to save you a trip. I'm not going to switch. And he name dropped a little bit, one of my co-residents and a few things. He let me know of some people that had tried the files and liked them. He said he was going to be making a little trip through the Midwest, and Wichita was on his agenda, which I thought, okay, yeah, right. And I know that I'm not from Wichita, but I've been here long enough to know that you don't usually go to Wichita on the way to anywhere. It's pretty much you're either going to Wichita or you're not. So anyway, he assured me it wouldn't be a waste of a trip, and he came down and gave me some products to use. And so my few minutes that I have with you today are to explain to you a little bit about my experience incorporating the Avalon Biomed files and sealer and putty into my daily workflow. The first product I tried, and that's what I have here on this slide, were the Slim Shaper files. And so, again, I was really happy with my files that I was currently using. I've done a lot of cases and a lot of cases successfully. I wasn't having a lot of trouble with the files or anything. I was happy. But the thing that caught my attention and the thing that I've highlighted here is the 3-alloy system, which was unique, at least in my experience. I wasn't aware of another system that used a gold alloy for the smaller file for cutting efficiency, and then a pink alloy for the one in the middle to get some sort of a balance between cutting efficiency and flexibility. And then the blue file, the largest one, that although it was blue and highly flexible, it still gave us some cutting ability, but we in reality needed more flexibility to resist things like cyclic fatigue as we were going around bends with the larger shapes. The other thing that caught my attention, and something that I had really been starting to try to incorporate in my root canals, is the maximum flute diameter of, in the largest size, 0.84 millimeters, really slim. I had told BJ that I would try the files. He was going to leave me some samples, so I thought, well, I'll give him a try. I'll let him know. I'll let him know what I thought, and that I was planning on telling him that, hey, these are great, but again, I'm happy with my old system. I'm not switching. These are just a few cases. These are pretty recent cases. I have a handful of cases that I've done with these. I thought these were cool cases to showcase the shape, the thin shape of the Slim Shaper files. As you know, you've all done these 3-rooted premolars, the mini molars, the infamous mini molars. And especially in Bruno will get into this in his presentation a little bit later, but when we're looking at these on the CT scan, that these roots are thin, they're delicate, they don't have a lot of dentin, mesial to distal, and by enlarging them in an attempt to enlarge the apical portion of the file, we can really remove a ton of pericervical dentin that gives the roots long-term resistance to cracking and fracture. Here's a couple other cases. This is a 5-rooted lower molar on the left. And again, you can see traditionally, like on a distal canal, I wouldn't use such a small shape, but this one had kind of 2 slender canals that joined into one. And then the other canals you can see that really have a nice shape that's respecting the natural anatomy of the tooth. And then the one on the upper right, so this is, and I wish I could run through the cone beam as well, but because of lack of time, I'm not going to do that. But you can see MB1 kind of went straight up, and then MB2 kind of branched off and took a sharp curve back towards the distal. And so I was able to get the size 20 Slim Shaper file around that and obturate it successfully without any instrument separation. So I was pretty happy about the results there. I had mentioned that I told BJ I wasn't switching, and in my mind I was thinking, if there's a huge compelling reason to switch, maybe I will. And I quickly realized, and I've kind of noted them here so you can see them in writing, that there were many very compelling reasons to switch. It was quick, which is awesome. We have a busy practice. We have a really great workflow. I like to get in, do the root canal, and get out. And I noticed that my treatment times were going down. I'd say 5 minutes here, 10 minutes there. And over the course of an 8 or 10 hour day, that really adds up. I mean, really, it's an extra 1 to 2 cases that I felt like I was getting in by saving 10 minutes here and 10 minutes there. I was using fewer files. The file system that I was using before, especially with the smaller files, like my 15 file, I noticed on the multi-rooted teeth that the files, they would start to unwind. I'd lose confidence in the file. I'd toss it, and then I'd bring in a new one. And I found that on some of the smaller cases, four rooted, four canal upper molars, maybe with an MB2, sometimes I was going through 2 or 3 or 4 of the size 15 files in an effort to get down to working length. And that is no longer the case with the Slim Shaper files. I already talked about the metallurgy, but really the change in the flexibility as you move up just really instills confidence, especially when going around the severely curved cases. Another thing that I thought was awesome that I wasn't really expecting was the accuracy of the gutta percha comb fits. I was finding that the comb fits were very accurate, more accurate than what I'd been using before. They were requiring very minimal adjustments and trimming of the cones to get them to get a nice fit with apical tug back. When we broke it down, we were using fewer files. The files themselves, the packs of files were less expensive than what we were paying. So that, of course, was a huge win, especially in today's economy with things that are getting increasingly expensive. And then the last thing, and honestly, this may be one of the most important things, is the receptive nature of the people at Avalon Biomed. Really, and this was everyone across the board. I went and I talked to them at the booth at AAE, and I told them, okay, this is what I like, this is what I don't like, this is where I think things can improve. And everyone was super receptive to what I had to say. And I quickly realized that it wasn't lip service. It wasn't all talk. And I'm going to show you on this next slide. So what we have here is on the very left, you can see the original size 25 or ZS3 as they call it file. And one thing you'll notice that is missing is the only way to know what size this file is either you memorize that the shank is blue, which is not usually the case for a size 25 file, or you look at the color of the stopper, because you can see here on the right. So the 25 size has a red stopper, the 20 a yellow, and the 15 a white stopper. My feedback, and it sounds like the feedback of other clinicians, was put a colored band on the shank of the file, just like every other file system out there. And so quickly they came back and said, hey, doc, we've got some good news for you. This is what we've done. And so you can see the new ones have the colored shank like you would expect. You still get the different colors to highlight the metallurgy differences, so the different colors in the metals, but the bands are just kind of one simple example of how Avalon Biomed listens to its customers. I wanted to put this file up here, or this page up here, so you can see my protocol, because I get a lot of questions about this. And you'll see I have some other brands of files on here as well. And I think that that's common. I don't think I'm the only one that does that. And I don't think anyone's really asking us to pick one brand and stick with the brand, because that's not how dentistry and endodontics is. So what I do, and I'll just quickly go through this, and then if there are specific questions afterwards, I'll hit those. I get an estimated working length on each canal from the CBCT, and we've gotten very accurate with that. Dr. Azevedo is going to talk about that as well. I access the tooth, knowing with confidence where the canals are going to be from the CBCT. I use the ProTaper Gold SX orifice opener on all the canals. For a path file, I like the Edge V taper. It's a 1403. It's a very kind of thin, flimsy file. And I feel like if I put that into the canal before I put hand files into the canal, I have a lot easier time getting down to working length. Once I get my working length with my apex locator, then boom, I'm going right to the Slim Shaper files. And at this point, it's off to the races. I've got my working length. I've already taken my path file down. and it's 15, 20, 25, and most of the cases I'm done and ready to obturate. On some of the larger cases, so like this case here that I'm showing, you can see the buccal roots are very slim and slender, and we were able to respect the natural anatomy there. But the palatal root is much larger than the largest of the slim shaper files. So in this case, what I did is I just used, and this is another Avalon Biomed product, this blue shaper. They're really great files. They work awesome if you need bigger sizes, bigger shapes, especially in the coronal portion of the canal. So in this case, I went up to so here it's called Z5. This is a size 30, and then I went to a size 40, and then I obturated this with a size 40 corresponding blue shaper gutta percha. Another product that I was quickly introduced to and also fell in love with for a number of reasons was the NeoSealer Flow. I was using another leading bioceramic sealer that, again, I had done thousands of cases with and I was pretty happy with. The NeoSealer caught my attention because of the radiopacity, because of some studies that I had recently come across, and also because of the cost. Another thing that was awesome is they were including these minimal waste tips rather than having to throw out the tips that were coming with my previous sealer and purchasing at an additional cost some minimal waste tips. Another thing that I really love about the bioceramic products from Avalon Biomed is that they're made right here in the United States. They're made in a lab in Houston, Texas, right here in USA. And again, the same people that are receptive to the changes in the files are the people that are receptive to the changes in the other products. Before I move on from this, I'll just say that my technique for obturation, on most cases, will use a single cone technique. So I'll finish with my master apical file. I'll confirm working length. I'll fill the canal passively with the NeoSealer Flow, and then one gutta percha cone to length. Now, those cases where we have a lot of space in the canal, maybe an upper incisor, palatal canal of an upper molar, distal canal of a lower molar, on those ones, I'll do some warm vertical condensation. And in that case, what I found is the NeoSealer Flow is really workable under high heat, which is great. I'm not getting like all that smoke coming up. I'm not getting the chalkiness of the sealer like I was getting with the other product that I was using. It maintains its consistency and allows me to pack it in and then kind of backfill. So it's been really great there. This is just kind of a little blurb for something that's not quite available, but very soon. I had the opportunity to test this in the clinic. I've used it on several cases. So this is like a high flow NeoSealer. It's called the NeoSealer Easy Flow. You get awesome radio opacity. This is really great for cases where you're using maybe the Edge Pro laser or the gentle wave or something like that to try and get some apical branches or lateral canals or things like that. This sealer will flow better than the original NeoSealer Flow into these areas. It maintains a great consistency. And one of the greatest parts about this is it comes with these Navi tips from Ultradent. They're tiny, tiny. I use the 29 gauge tips. You can actually use a 30 gauge tip and get consistent flow. So on these minimal shapes, if you're trying to get all the way to apex and control the amount of sealer that you're placing into the canal, these Navi tip tips that go on the NeoSealer and that come with the NeoSealer are fantastic. So again, you're not purchasing additional stuff and discarding the tips that you're already paying for with the product. They come included, which is a huge plus in our practice. Quickly, the Neo Putty. I had already been using this product. This was the only Avalon Biomed product that I had been using before I talked with BJ about a year ago. I use this on all of my apicoectomies, and it has an awesome shelf life. I've never had it like dry out or had to toss a syringe of it or anything like that. It's very consistent. It's very manageable. It sticks to the end of the instrument that I use to apply it to the retrofills. So it's really great. The way I do it is I use the NeoSealer Flow I'll fill the retro prep with a little tiny amount of the Neo Sealer flow, actually till it's kind of overflowing, and then I'll just put the lid on with the Neo Putty. Kind of I guess maybe a somewhat common technique, but something that I've done with the Neo Sealer flow and the Neo Putty, and I've done probably 100 surgeries with that, and it's worked fantastic. This is just an image of a surgery I did recently. Again, these aren't cherry picked. These are like within the past week or two. So this is just kind of, I mainly put this up here so you can see the radial opacity. I cut this one back for those that are critiquing the amount of root that I resected. I felt like I had to cut it back a lot. I was seeing what appeared to be some cracking. I thought there was kind of a lateral branch there near the cyst or granuloma they're forming on the lateral side of that premolar. So, but again, the radial opacity is really fantastic of the Neo Putty. Here's another use case of the Neo Putty. This was this week, 2 or 3 days ago, I think probably Monday. This is a young patient, 9 years old, I think. He presented having some discomfort, pulpitis on this tooth number 19. In these cases, I mean, you always have the dilemma. Do I obturate the case? Do I do a full root canal? Do I try and do some vital pulp therapy for apexogenesis and try and get things to develop a little further along the root, the dentin a little thicker, the end of the roots to close up a little bit more? I decided to do a pulpotomy. I removed some caries that was under the initial filling. So you can see that the chamber was filled with the Neo Putty. I placed a resin liner over the top of that and then filled with a resin. So this is a case that I'll follow. I have every reason to expect that we'll see a little bit of continued root development. Again, we're not searching for a ton, but I thought in this case with such a young patient, I think it was a good and appropriate choice. Although doing the full root canal probably would have been appropriate as well. And then this is a case from today. And the reason why I showed this case, so I was retreating a case that came in from another general dentist. There was a file here in the mesiobuccal canal that you can see. I was able to remove that, work my way down, and achieve patency on all the canals. The one thing that I was finding, and I know that you deal with this all the time, is this huge lesion here. It was just draining and draining and draining and draining. I used the Edge Pro laser. I tried to flush it, and I just continued to get some purulence coming from the end of the root. So what I did here was I dried the best that I could, and then after I had done all my instrumentation and confirmed my working length, and then I put a little tiny amount of the Neo Putty into the mesial canals. And I use my gutta percha point to push those down and to basically do a plug at the apex there. And as soon as I did that, I got no more drainage from the apical portion of the tooth. And I did some more disinfection above the apical plug that I placed, and then I obturated. Early on in my career, and some of you may do it like this, again, there are lots of ways to do root canals. I would have medicated this case and brought the patient back in 4 weeks or 6 weeks or something like that. Because I used the laser in this case, I had more confidence going in and finishing this case in one visit rather than medicating the case. And I feel very confident about placing the apical plugs in a bioceramic like the Neo Putty, knowing that I can expect some full bone formation there at the root apex as the tooth heals. Lastly, here's my email address, my account on Instagram. I know that probably not all of you will get to ask questions, and you might sleep on it and think, hey, I wish I would have asked Jake this or that. Feel free to send me an email or a direct message on Instagram, and I'd be happy to help in any way. Thanks.
Dr. Butler. Hey, Dr. Butler. There was one question here talking about when you saw the use of your slim shapers, what kind of changes did you see initially with maybe the stress level of the files unwinding or potentially changing from your use and experience other files in the market?
Yeah, great question. So when I put these files to the test, me and my partner, Dr. Hoffman, we pushed the files. So we wanted to push. We didn't go in babying the files, trying to see, okay, are these going to work in ideal situations? We push the files to see how they'd respond under stress, of course, within limits, but I definitely am not getting the unwinding and the discarding of the files, and I had mentioned that in my presentation. The one thing I will say though is once I've gotten down to my working length with the size 15, the ZS1 file, if I've pushed that file hard, I'll throw it out, even though it's not showing signs of fatigue or wear, just because I know that I've used that and it'll be a file that I discard. Once I've gotten that initial 15 file down to length, then I have more confidence in the greater flexibility of the pink and the blue alloys as we go up to size 20 and to size 25. And so those ones I'll use, and I have actually confidence using those a second time, cleaning those and reusing those a second time. So another money saver in our practice. Did that answer the question?
It did. Thank you so much.
Welcome. Anything else?
Another question is talking about corresponding gutta percha points.
Mhm.
Can you please elaborate on that?
Yeah, so all of the file systems, and again, I just spoke briefly on the slim shapers and the blue shapers, but there's a reciprocating file called the Excalibur, and there's an apical shaper, and they all have corresponding gutta percha. So you're not using like a generic gutta percha, you're not using like a gutta percha from a different brand and trying to get it to work or fit, or you're not like having to like size down a different brand or anything like that. There's a corresponding gutta percha, and I found that it fits very well. Another thing that I really like about the gutta percha is the ability to sear it off cleanly. There's one brand in particular that I've used a lot, and I like the fit of the gutta percha, but I hate trying to sear it. I feel like I can put all the heat in the world, and it just like doesn't want to sear with a heated plugger. And so this gutta percha, it handles awesome. I'm able to sear it and then pack it in the coronal 2 or 3 millimeters. And so it's just a good fit. It's quick, especially if you're doing like the single cone like me. You feel like you get really good tug back. You can fit it to length. You sear it off, you pack it, and that's it.
Perfect. Thank you so much for that.
Okay.
One last question says, can you spin the slim shapers and reciprocation? And then why don't you elaborate on Excaliburs?
Okay, so the slim shapers, no, at least to my knowledge, those cannot be used in reciprocating fashion. Those are used fast, like 500 RPMs, 500 to maybe 520, I think is what the manufacturer recommends. I run them at 500 and 2.5 Newton centimeters of torque. And I haven't tried running them in reciprocation, but I know that they won't cut that way. And then the Excaliburs, I've actually gone back and forth in my larger canals between using the blue shaper and the Excalibur. And so the Excalibur, like if you're used to using like the Wave 1 Gold, I know that there are a lot of dental schools that teach that, and that kind of continues into use in the clinical setting. So the Excalibur functions just like the Wave 1 files. So same setting, you use the wave setting on your motor and everything.
So easy transition for whatever motor they're working with, you're saying.
Yep. And on mine, I have a setting that's a reciprocating setting. I just have like the 1 through 5 or 6 or whatever settings on the motor. And so I just, if I do end up using the Excalibur, I just flip it over to reciprocating and put it on. I don't find it cumbersome or anything like that, but there has been a time or two where I have forgotten to switch it over, and you know that you're in the wrong setting because it doesn't go. It doesn't cut, it just kind of spins.
Very true. Additional question here is the Neil putty that they tried a year ago did not maintain its shape while being placed during apicos. Have you had any trouble with this with working with Neil putty?
I haven't had any trouble. I wasn't aware of that complaint. I'm not exactly sure. And maybe it's being compared with I'm trying to think what the consistency was of the Brasseler product, the BC putty, I think is what it's called. How we do it is we'll just dispense a tiny amount and kind of roll it into a cylinder and then place it on an instrument, and it seems to hold its shape. I don't like when I'm carrying it from my assistant hands it to me, and I like that it sticks to the instrument, and then I place it into a retro prep that has already been filled with the NeoSealer flow, so the sealer, the bioceramic sealer, and I'll do that. I probably use an excess because I'll do it like 3 times, even though I know that it's like already full. But I haven't noticed that. I mean, maybe I'll pay attention to it to see if it loses shape, but that's not something. I mean, I'll just use tiny increments of it. But I mean, my retro preps are 3 to 6 millimeters, and so they're not huge amounts that I'm dispensing.
Okay, perfect. Well, thank you for the Q&A there. We're now going to
Oh,
transition.
one other thing I'll mention real quick, and then we'll turn the time over to Bruno. I haven't, because I've been using the Neo Putty for longer. Maybe I don't know. I couldn't estimate. Maybe 2 years or something like that. I haven't noticed it. I haven't seen like any instances of it washing out or anything like that. Even in the presence of like a crypt that's got heavy bleeding or something like that. I've never had any cases where it's washed out or fallen out.
Thank you.
Thanks.
AJ, great presentation. Can you hear me well?
Yes, thanks.
Perfect. Awesome. How are you guys tonight? Doing okay? All right. So let me get to my PowerPoint here. And presentation goes up. There we go. I'm gonna hide this guy. Corner. And I'm gonna hide this guy here. And I'm gonna hide my controls. There we go. So good evening, everybody. Pleasure to be here talking to you guys. Big shout out to Avalon for inviting me to be here. As you probably know, I've been in the endo world forever, but as a clinician, I only started doing root canals in the past 18 months. So I'm here talking to you from Philadelphia. Currently, I am a second-year resident at Einstein. So I have 6 more months to go. I'll be moving to Austin, Texas here very soon, opening a private practice there. And the first time I actually heard of Avalon as a company was last year. I went to APSIS and I had a chance to, for the first time, get a package of the sealer to test out. One of the things that immediately fell in love with was actually with the tips, like the tips that Jake was talking about. They're great. I really enjoy them. I think they're a little bit longer than the average tip out there, a little bit stiffer. I just really like them. So that was my first contact with Avalon. Fast forward to the AAE this year, and I'm hearing from a lot of my colleagues in endodontics going, man, I love those Avalon files. They're great. And I was like, Avalon has files. I didn't know anything about it. And during the meeting, during the AAE meeting this year, I actually got to talk to Mike Braun and Mike Bruno. You're a resident. Can you please try our files and see what you're going to think about it? And that's what I did. So I just got a sample. And from there, I was waiting for an opportunity that I thought, okay, let me put this file for the test. So I'm going to show you a resident case, right? That it was my first case with slim shapers. So basically, I had this young girl came in with a hot number 18. This tooth was, she's in a lot of pain. Long story short, I'm looking at this PA. And as I am evaluating those mesials canals, I'm going, oh my goodness, I have this, bayonet shape here, sort of a mesios. This is not going to be an easy one. As you guys know, with my background in imaging, I heavily rely on my 3D scans. So the idea here is I'm always trying to leverage cone beam to help me map anatomy, help me visualize what the 3D anatomy of this tooth is going to look like. So ideally speaking, what I like to do is I like to go up and down with my axials, kind of following the long axis of what the file is going to do. So this way, if I know I'm on this particular orientation here, I understand that I'm going to ask a lot of my file, particularly to go through that mesial with that very severe curve, right? So I show this case to my program director, Dr. Barnett, and immediately he tells me, you have to be very careful with this tooth. We used to call this a widowmaker. This is definitely a case that if you're not careful with your files and you don't use the correct files here, it's going to separate. It's going to create a lot of stress, and it's going to be a very hard case for you to work on. So with that in mind, knowing that mesioanatomy was so unusual, right? My whole idea here was, okay, what am I going to encounter? So when I access the tooth, one of the things that I like to do, it's always to look at the pulpal floor. So I'm always mapping the pulpal floor as well, because after I finish my access, this is what I'm going to see. So I'm going there, and I'm going with my, going with my 3D rendering and showing, okay, the distal root, I'm not as a concern here, but definitely those mesials, where I'm going to find, the mesiobuccal and mesiolingual, I'm definitely going to have some problems. Particularly, they curve a lot. They absolutely curve a lot. So as I keep making my analysis, one of the things that I also enjoy doing is I'm going to keep going down with my 3D render. Now it's showing me how the canal is going to curve, so I can appreciate every little curve that my file is going to do before I get in there. So ideally speaking, I was like, okay, so Avalon told me that those files are awesome. They are they're slim. I can go there, be very minimally invasive, and they are going to be they're going to allow me to conquer those crazy curves. So as I was looking at my package, I just wanted to say, okay, can I start with my golden, then switch to my pink, and switch to my blue? We have given nickname to those files. We call them the cotton candy files. I think they have the sexiest colors of all the files I've ever seen. And it makes it very easy for me to know the sequence as well. So I started with my Z1 and went straight to my Z2. For the distal, I went all the way to a Z3. And shaping of those canals was pretty much a breeze. I had no problem whatsoever. Here at Einstein, we use advanced irrigation. So as you can see here, I got to patency really well, following all the curves. And then from this point on, we are heavily into advanced irrigation. So in this particular case, I did run gentle wave on it. And after the gentle wave cycle was completed, I was able to obturate the canal. So, for somebody that hasn't touched a handpiece in 22 years, and be able to come back and work those cases using this particular file, I can honestly tell you that they work. They work great in my hands. I'm quite sure if you're more experienced than endodontists, will work in your hands as well. Then secondly, I wanted to also show you a very interesting case I did using this. And this was actually from a patient that came into Einstein with a referral from a general dentist. And what they wanted me to do is retreat or try to treat number 13. So basically, this general dentist came in, and this patient came in with a SIP-SAP on this tooth. General dentist tried to access the tooth. Unfortunately, could not find any canal. At least the general dentist was smart enough to realize that he was in an area that it was not his expertise. So he stopped, closed the case, sent the patient to Einstein. Funny enough, I'm a big guy. This guy is much bigger than me. He's like a Viking. He's like 6'7", 350 pounds, a big dude. Comes in, and I'm trying to see how I'm gonna, tackle this case. And interesting enough, as we're running this, I also access this tooth, run my my photona laser on it, and immediately I can get into that canal. Here is the cone fit of a Z2. So I was able to instrument this case all the way down with a Z2. And here is the final obturation with a fiber post. So I have to agree with Jake 100%. The system is pretty easy to use. The Gouda Percha matches the file beautifully. And I don't anticipate you guys having any problems with the file whatsoever. They can, get to some crazy curves, get down to some of those straight canals. And I feel that the system is very, very solid. So particularly when you use advanced irrigation like Jake does with his Edge Pro, or we do here at Einstein with all the lasers and the gentle waves that we have. But one of the things that I also wanted to talk about tonight is just to make sure that you guys can leverage cone beam when you're doing your endo. So one of the things that I have learned is there are multiple ways to do a root canal. There are 1,000 ways to skin a cat, as we say it. but there's only one correct diagnosis. It's really, really important that we understand that whenever we're doing a root canal, we have to make sure that the diagnosis that we have is correct, that the anatomy that we're mapping is correct, and we are prepared for everything that the tooth and the surroundings of that tooth is going to give us. So it's important that we understand that when we are looking at performing a root canal for a patient, we're going to have an impact on your diagnosis, on the technologies that you use, and the more nuances you have, the better training, the more advances that we got, better outcomes are gonna rise, and it's gonna make our life, like Jake was showing, better, faster, way more more predictable and more profitable. Why not, right? Because we, in the end of the day, we're doing the business too. So whenever we're looking at teeth, I urge you to realize that we are not dealing with anatomy that's simple. You know, every time that we're trying to negotiate any of those canals, a file can do so much. You know, right now we're doing chemical warfare together with mechanical warfare on bacteria that lives inside those canals, on, of course, the cases with AP. And it's important that we realize that no matter where you are at your stage of your career, if you're a beginner or if you are a more seasoned clinician, you know, the idea that in order to map anatomy with two-dimensional imaging is just in 2023 just not sound. I can understand folks that do not have access to 3D imaging, you know, depending on where they practice. But for those who have access to 3D imaging and refuse to use it just for the sole purpose that, oh, this image right here is showing everything I need to know, I have to tell you, in 2023, you're fundamentally wrong. You know, a two-dimensional image or anything that only shows you mesiodistal will fundamentally impact the quality of what you're trying to do, regardless of the file systems or the advanced irrigation system that you guys are going to use. And the reason for that is every tooth, no matter what it is, it can be the anterior maxilla, it can be, you know, a posterior molar, it will always have complex anatomy. And I also want you to understand that around that tooth, we're also going to have, it's always going to have complex anatomy. And why is complex anatomy important? And for us to understand that what we're dealing is not as simple, it's just not putting a file there. It's important for you to understand this, because when we actually look what those anatomy looks like in reality, right, from micro CTs, we understand there's just so much a file can do, or particularly when we're looking in diagnosis. So it's really, really important that you guys try as much as you can, map that information in 3D. So with the right file system, we can go in there, clean and reshape those canals, and allow us to use, you know, the most advanced irrigation systems that we can try to get our hands on, to really wage chemical warfare to the tissue and to the bacteria that lives inside those crazy anatomy canals. And the idea that two-dimensional imaging can map such complicated anatomy in 2023, we know it's ridiculous. We know it doesn't exist. And we have to really embrace three-dimensional imaging as we move forward with endodontics, before, during, and after. So with that said, you know, when we go to the literature, what is it that we know? That the root canal morphology configuration presents a complex anatomy and requires, you know, more diagnosis approaches. You know, that's when we're going to go back and change the axis, and with the better clinical skills you have, and of course with the best technology you can put in your hands with the right files, we can achieve excellent predictable results. So when we talk about two-dimensional imaging, it's important to remember that this is not really giving us information that we actually need to be successful. So if you were to look at this particular PA right now, and I were to ask you, which one of those teeth, one that you're going to extract, one that you're going to retreat, and another one that you're going to do an apical surgery, you wouldn't be able to answer this question just solely based on a PA. And the reason for that, it's because you will never be able to realize that the tooth that you actually is going to extract is going to be tooth number 9, because that fracture that you see right here cannot be appreciated with two-dimensional imaging, right? So there's too much superimposition, too much missed opportunities and misinformation when we are not embracing three-dimensional imaging in our practices. Another thing that's important for you guys to realize is that there are a lot of times that when we look at the apical aspect of this type of case, this is one of my patients here at Einstein, where I was looking at to do another root canal on a number 18, single canal, very long tooth. But when you look at the proximity of that root canal to the mandibular canal, that makes you sweat a little bit, right? So one of the things that I get questions all the time is, do you like sealer puffs, Bruno? Are you doing sealer puffs? And, Rikuchi says no sealer puff, some other things, some other endodontists, they're all getting sealer puffs. So my answer to that is, the way I see a sealer puff are case dependent. If the case allows me to add a sealer puff, I have no problem. But on this particular situation here, when we are looking at this particular tooth, and we are now, again, doing exactly what I told you. I'm going to investigate what my axis is going to look like. I'm going to look here, look at straight into the decay. I can go in and look straight into where my axis is going to be, because that's where the decay is. And as I move towards the 3D rendering, I can appreciate the fact now that this is a single rooted canal. And as I'm looking down, I know exactly where I want to go. I know exactly what the stress my file is going to have, if there is a curve or no curve. So in this particular case, it goes straight down, but right in the end, there is a curve. And the interesting thing is, when you actually look at that curve, it's superimposing the mandibular canal right there. So in this particular case, regardless of the sealer that you want to use, this is a situation where you don't want a sealer puff, right? You actually want to be very conservative on those types of cases. You want to make sure that on this case, you are on point with your working length, with your instrumentation, and of course, with your obturation. So here is the final case on this particular situation. I was super happy with the results. Patient is healing beautifully. And here is the cone beam showing that exactly what I wanted. No puff, but obturated all the way to the end of the root. Now, one of the things that I see endodontists asking me all the time is, Bruno, but I understand a molar, but I don't understand a center incisor. If I see a center incisor, I really don't care too much about it. It's too simple. So once in a blue moon, the endogods will give us one of those easy cases that I can just come in and do a straight root canal on a number 8 or a number 9 or a number 7 or number 10, and it's pretty straightforward. I dare to say that nothing in endodontics is straightforward. The anatomy that we're dealing with, it's always going to be complex no matter what, because we really don't know where the exit of those foramens are, what is the surrounding anatomy associated with those foramens. And I dare to say that, situations like this, where the exit foramen is pretty large, and it's perforating the cortical outline, I'm scared. I know that there are sodium hypochlorite accidents that can happen in this area, depending on who the patient is and how aggressive I am going with my irrigation. So there is always information there, even on the anterior dentition, that allows you to be a better clinician and allows you to better understand how to approach the case. So I don't want you to think about that just because I'm just doing an anterior tooth, I don't need 3D imaging. Because I am 100% sure that everybody that saw the previous case where I was showing you tooth number 18, we're in agreement. Bruno, yeah, that's a great case for the use of cone beam, right? But what folks don't realize is the reason why you're so afraid of the mandibular molars is because you're close to a nerve. You're close to an area that you were taught in dental school is very dangerous. But unfortunately, we don't learn 3D anatomy in residency, and we don't learn 3D anatomy in dental school. So when we look, for example, at the vascularity of the sinus, here's your PSAA. Okay, your PSAA does an anastomosis with your infraorbital foramen, and as you see your infraorbital foramen here, it gives birth to a canal. This is called the canalis sinuosus right there. Okay, so the canalis sinuosus is giving the, it's coming out from the joining of the PSAA and the infraorbital foramen. And as those guys join, guess where they're going to go? It's going to go laterally to the nasal fossa, and it's going to go right at the area of the central incisors, the canines, and or the laterals. And this guy can be very complicated. So when we evaluate, for example, PAs, it's not uncommon for us to have the situation here where you see this little apical lesion close to a canine, but when you actually look from a cross-sectional perspective, this apical area here is not a lesion, is just, again, the canalis sinuosus coming around. So if you are afraid of doing a root canal on a mandibular molar, right, without combing, because you might be too close to the mandibular nerve, and you want to make sure that you're not, getting sealer or any type of instrumentation inside that canal, what would you say to the anterior dentition? We have to realize that if you don't understand and you don't map the anatomy of the anterior dentition, this situation can happen. So look, we are talking now of the canalis sinuosus here on this particular patient. And as we're looking at the canalis sinuosus right in this area, right where the lateral incisor is, when we move, okay, the sagittal view here, you will see that the canalis sinuosus is exactly where the exit foramen of that tooth is. So in my book, there is no difference on doing a root canal on that number 18 that I showed you versus doing a root canal here on this number 10, because they're both in contact or in close proximity of very important anatomical structures. So I guess what I'm trying to tell you is, do not judge a book by its cover. Don't think that, oh my God, I'm doing an anterior tooth, I don't need a comb being here, it's going to be straightforward. Do not do that, because we don't know. We really don't know what's going on when it comes to anatomy. And last, I just saw that one of my colleagues is on attendance tonight. So big shout out here to Dr. Michael Thompson from Arizona. So this is how much we don't know about dentistry. So this is the first time I actually saw this particular anatomical variation here. Ever since I saw this, I have collected 8 cases now that look exactly like this, and they all are very typical. They tend to happen on second molars, particularly mandible. They tend to happen on women. Okay, out of the 8 cases I have, 6 are on women, 2 are on males. So what am I talking about here? So we tend to think that the apical part of the dentition it's where the problem is, right? But let's take a look at this number 18, that the patient was in pain, irreversible pulpitis. As we're scrolling through the anatomy, what you guys are going to see is this canal right there. Okay, so this canal right here, it's actually a branch from the mandibular canal. All right, so this is a branch from the mandibular canal. So it's going from the mandibular canal, going through the tooth, doing anastomosis with the pulp, and coming out on the other side. So there's so much about endodontics that we know, but there's so much more that we don't know. So I urge you guys to embrace technology, embrace imaging, and also embrace the files that are going to work really good on your hands, and just like Jake demonstrated and I showed on a couple of my way more simpler cases, that the Avalon files is a great system. So with that said, I think my 30 minutes are up, and I'll be happy to entertain any questions you guys may have. Thanks for your time.
Thank you, Dr. Azevedo, for that enlightening conversation and presentation. There are some questions here from the audience, and the first one that we have here is, when taking a CBCT, do you still recommend maxing out the settings?
Absolutely. Yes, that's an easy question. Yes.
Okay. Then what software are you using for the 3D rendering?
So I'm using Evol. This is what I use for my private practice. We have it Evol here at Einstein as well. But you can have pretty much any software out there will have similar features that you can work with. But Evol is what I use. It's a little bit more powerful. It's AI driven. And what I was showing you guys were task-specific rendering of the anatomy. So this is how I typically use my cases. I try to, as much as I can, maximize and leverage cone beam to my advantage. So as I was showing you, I'm always navigating the axial images up and down, so I have a better understanding on where it's curves, on how deep is the curves, or where is the split, so I can put a little bend on a file and try to find it. Or it's not uncommon for me to also design my access with the cone beam. Actually, we'll have a webinar coming soon, very soon, on how to design access with cone beam CT imaging. And that has been a game changing in the way I access teeth, and can be very conservative with my accesses. And you know, I try as much as I can possibly to use technology on my advantage. You know, like I said, I'm really good with imaging, but I'm really fairly new to the clinical setting. So I have to figure out ways that allows me to maximize the technology that I have to allow me to close that gap between me and more experienced clinicians. And I think that the last 18 months have taught me a lot on how to do that. And I'm very confident right now that, you know, particularly when I'm using, you know, great files and with the diagnostic background that I have, that I can do really good root canals with good outcomes to the advantage, my advantage and advantage of my patients.
Thank you. We'll have one more question here, just to be cognizant of time. It's Chandler can wrap it up. It says, so for the case with the IA nerve that goes in and merges with number 18, can that be treated, or is that going to result in paresthesia?
No, there was no paresthesia whatsoever on that patient. You know, but if you had sealer sort of exposure there, I'm sorry, a sealer puff, it could result in paresthesia for sure. So we have many cases in the literature that shows that. I've seen a lot of legal cases, unfortunately, where sealer or sodium chloride or even calcium hydroxide that goes into contact with the nerve can lead to paresthesia. So be careful. That's why I always tell folks that we tend to be selective when it comes to sealer puffs. You know, if it's in an area that is far away from the nerve, yes, I do want to see the sealer puff. I do it all the time. But if it's on an area where, you know, you can be close to the canalis sinuosus or close to the mandibular canal, or to another area that can be problematic, perhaps you want to be a little bit more conservative with your sealer puffs there. That's the take-home message. And the only way you're going to know this is if you have 3D imaging to help you better understand what the anatomy of the tooth is and the area surrounding the tooth. The anatomy surrounding the tooth also is.